Our next speaker, Dr. Byron C. Calhoun, is a specialist in the management of high-risk obstetrics and the medical complications of pregnancy, and has managed thousands of high-risk pregnancies. He is Professor and Vice Chair in the Department of Obstetrics and Gynecology in West Virginia University, Charleston. His practice and clinical research is concentrated on pregnancies complicated by maternal and/or fetal disease, being a specialist in maternal fetal medicine. He has authored 68 peer-review articles in the obstetric and gynecologic literature, has presented in excess of 100 scientific papers, and participated in more than 40 research projects. He is also a peer reviewer for a myriad of medical journals, including the American Journal of Obstetrics and Gynecology, Obstetrics and Gynecology, the American Journal of Managed Care, the Journal of Maternal Fetal Medicine, Fetal Diagnosis and Therapy, and Journal of Reproductive Medicine. Later today, Dr. Calhoun will address this symposium on managing the challenges of high-risk pregnancies. However, he is also an original author of the Perinatal Hospice concept, which provides multidisciplinary care to families with a poor prenatal diagnosis. And we will hear from him now on the subject of perinatal hospice and providing a comprehensive care model for families with fatal prenatal diagnoses. Please join me in giving a very warm welcome to Dr. Byron C. Calhoun.
Thank you very much. Can everybody hear me in the back, or do I need to get the handheld mic? Are we all right? Can we hear me in the back? No feedback? Great. Thank you very much. I'd like to thank Professor Dwyer and the committee for inviting me to do this. It is one of my passions. I do a great deal of prenatal diagnosis as a maternal fetal medicine and do a lot of ultrasound. So for patients who have an adverse prenatal diagnosis, this is really near and dear to my heart. And so without further talking about that, we'll go on this journey. If I'm too fast, raise your hand. I'll try to slow down, but I have a small amount of time and a lot to cover, so I'll move rather rapidly. Basically, for those of you like my wife that are German and like to know, or Scots, as I say in my family, like to know where you're going because you're very much into Ordnung. We're going to talk about introduction a little bit, what hospice concepts there are, define what perinatal hospice is, how we do it, or some concepts, a framework, the results that I've seen in at least 2 places that I've been, and some of the challenges that are continuing to be a part of this particular concept. Objectives basically are to understand that there is this need for people to have a cogent plan for those who have a child with an adverse prenatal diagnosis. Again, just refresh a little bit about general hospice and how this differs but yet is very similar. Also to understand how to do this. In other words, if you locally want to put a hospice into play, how you might do that. And the final thing is how you could do that, sort of empowering local providers and systems, how they might create it within their own healthcare system. I like to show pictures of my family because I think you need to know who I am. This is me with my beautiful little granddaughter, my first granddaughter, Katie, and this is in Disney World. So as you see pictures of my family or ask questions, feel free to laugh or just be totally bored by that. But I like it, so I'll show it. Well, why do we really care? Well, if you look at the data, there's an increasing ability to diagnose fetal anomalies. And I know if you're like myself, as Monique said, older than dirt and trained when Moses left Michigan, as I say in the U.S., we had very poor ultrasound. Now we have 3D ultrasound, real-time 3D, 4D, and the ability to diagnose multiple anomalies at a much higher level than we were able to do before. Yet birth defects in the United States, in our country, are still the leading cause of neonatal death, approximately 0.2 to 0.3%, and for us that's about 6,000 to 10,000 per year. You can equate that to Ireland's birth rate and figure out roughly how many babies are affected by some sort of lethal fetal anomaly, anencephaly, and other things of that nature, renal agenesis. Well, previously when we talked a lot about this, and this included my training before I got interested in this, the idea was well-intentioned, I think, to spare mothers and families and do something to get it over with. I mean, being a surgeon and an obstetrician, we always wanted to do something. We always wanted to do something and help discomfort our bereaved parents, our patients. A lot of this, I think, is to help treat our own discomfort, frankly. At least that's been my own personal experience. And I think there was a real increased fear of mortality in moms that had been talked about for many years, but was not well researched or actually even substantiated, as we'll find out. I like to show pictures of my mother. I call her the Stern Lady. She will actually be 95 this month, and she'd be horrified if I showed you this picture of her in her sweatshirt, but That's the best I could get because you won't ever pose, right? You know what mothers are like, yeah. Well, what about grief after termination? Well, if you look at a small case control study that was done actually in the Netherlands, they did 23 women who did terminations of pregnancy or abortion for anomalies and assessed grief responses at 2 months. What they found was that a significant number of these women had major depression. In other words, they weren't really over with it. And about 5 of the 23 or 22% had actually already sought psychiatric counseling. Now, this is at 2 months. So just keep that in the back of your mind for just a moment. There was another study then done in the Netherlands with 147 women. What they said, well, let's look at what happens farther out. Perhaps it improves with time. Actually, what they found at 4 months out, which is, again, 2 months farther, 46% of these women revealed pathological levels of what's considered a post-traumatic stress disease or syndrome. Idea that you're having intrusive nightmares, you're having dreams, you're hearing the baby cry, you can't function, you can't be around children, you can't be around babies. All of these things are part of this whole idea of a post-traumatic stress reaction by these women. And at 16 months, 21%. Now, you're talking a year and a half later, they're still having symptoms, okay? Another cross-section analysis done in 253 women, now 2 to 7 years out. I'm trying to paint your picture recent, middle, now far out. Years later now, they found that at least 3%, or roughly 2.6 to 3%, still had pathological grief. No surprise. And at 17% still suffered from some form of post-traumatic stress syndrome or post-traumatic stress with intrusive dreams, inability to function, and inability to be around children or babies. So very significant amounts of psychological trauma. Well, then there was another study that was looked at, and they said, well, what about just first trimester losses? Because unfortunately, as much as people talk about it, nobody talks about first trimester loss, at least in my country, and it's very poorly researched and understood. But at least this group said, well, let's look at what happens in first trimester loss and what happens with live birth and compare them prospectively in a cohort way. At the first 6 months, they did find increased depression, anxiety, and somatization, which would sort of be not surprising at 6 months, but by 1 year they had resolved that and there was actually no difference between the two groups, in contrast to the people who actually had terminations for anomalies. So I want you to understand, people just don't get over this when you do abortions. I like to show this because this is my beautiful daughter at 18 weeks, and she's actually sucking her thumb, and she's much more beautiful in the back now, and you'll see her back there, a little blonde girl, very beautiful. She looks like her mother, thank goodness. And finally, because I believe that people should be given care that they would like to have, and there's some idea of autonomy and choice, there was a large study done in 2002 with 53,000 pregnancies, found that 20% of patients want to carry their babies no matter what. And what I found when I was working in maternal fetal medicine, that nobody was dealing with this at all, really. I mean, they just weren't addressing this. I also said, well, what about mortality? Well, if you look at mortality rates at 16 to 20 weeks for induced abortion, at least the last statistics that I have, and I haven't seen any more recent ones yet, there may be some new ones coming out, and look at data from maternal mortality, it's roughly the same. And the reason I use 16 to 20 weeks is because that's when most anomalies are seen, at least in my country, and when you would do an intervention or an abortion. So no increase in mortality rate. My lovely first wife, Catherine, I always like to show pictures of her. Again, you get to see I'm not just de novo here. I actually have people that allow me to do this stuff, which I really appreciate. Well, what about hospice care? I'm sure a lot of you, because you're from the UK, are very familiar with the hospice concept. And the idea is that instead of putting people in rooms and ignoring them and pretending they're dead when they're not, you should deal with the medical pain issues. You should deal with basically the idea of withdrawal. The most common thing that my patients and every patient I've met in the hospice world deal with is actually withdrawal or abandonment. And that's why the hospice framework is very useful for the perinatal world. The idea is to hold patients close and not abandon them. And it also allows it to be family-centered for the parents, for grandparents, children, and everyone else who's involved in the care of the patients. Well, we actually looked also at some of the neonatal models, but really, neonatal's just too late. After babies are born, it's really not a good time to try to figure out about anticipatory grief, about plans, about how to deal with labor and delivery, about how to deal with family. That really needs to be done far ahead. So the question we asked, and my partners and I asked, was, what do you do with a terminally ill baby that's in utero? And here's where I'm going to ask my very cogent question. I know this is going to sound really simplistic. Who in here is going to get out of life alive? Would you raise your hand? Oh, none of you are. Thank you. I really appreciate you affirming that, because my thought is no one gets out of life alive. It's just a matter of when you might leave this earth, not if you're going to leave this earth. I love this picture. This is my beautiful little red-haired Irish little girl, Penelope, my latest grandchild. And yes, she is as sweet as she is there. You don't even have a baby in the house. Really weird. All right, so what is perinatal hospice? This is our definition, and this is what we'll stick with, and this is what we'll talk about. A prenatal diagnosis of a terminally ill fetus in utero leading to perinatal hospice as part of the continuation or the continuum of the end-of-life care. In other words, let's just care for these babies and their parents as if they were a hospice patient like any other and provide the same sorts of care. Now, what kind of care is it? It seems like, again, very simplistic, but if you don't think it through, as many things are, it just doesn't go very well. It needs to have the emotional needs of the patients met, spiritual needs of the patients met, psychosocial, medical obstetrics in particular, and care for the entire family. It's interdisciplinary and multidisciplinary, and I'll talk a little bit about who I involve with what I do. And it's coordinated. I'm a big believer. I know most people laugh when you talk about birthing plans. I know it's like, oh my goodness, that's this recipe for cesarean, right? But no, in this case, a birthing plan is critically important to help people understand what they want and what people want and what you do in labor and delivery and what you do subsequent to the birth. Critically important to get everybody all on the same page. Well, how do we do it? Well, we use a decision algorithm based on confirmed prenatal diagnosis. In spite of what people think, you know, physicians are not God, they are not omniscient, they are not omnipresent, they are not all-knowing, and I fully understand that. So I'm very careful to make sure that I only include babies that are terminally ill, particularly anencephalics, renal agenesis, children with multiple anomalies and significant chromosomal issues that are not going to survive for very long after birth. I confirm my diagnosis, and I use chromosomal studies and anatomy surveys, and I'm of the opinion that since I'm, again, not godlike, I send my patients to other physicians who are more skilled than I am in certain areas of maternal fetal medicine. So I do that as well. Again, focus is on the patient and on the family. Remember, everybody said we need to do something. Well, the something we do is we take care of the patient and we take care of her family. We provide them accessibility and support. We reassure them that this is something that is not unhealthy for her. It will not increase mortality. It will not increase morbidity, and I'll show you my numbers. Compassion and not abandonment, and it's an alternative for patients. And it's presented explicitly as an alternative and an option for them to have for their pregnancy. One of my favorite things about this is that Amy Kubelbeck says it allows the parents to be parents. And that's really what most of my patients want. I don't know what yours want, but my patients want to be parents. That's really what they want. This is my oldest daughter. Sounds terrible. Her name is Floppy Faith. Actually, it's Faith, but I call her Floppy. She has hypotonia, and she requires full-time care, but delightful child. You would not know it if you met her. She's very engaging. Well, how do we do this? Well, if you're like me at a tertiary care center, not like poor Dr. Kajia, who's in the middle of the African bush, right? I have a perinatal staff. I have neonatologists that I talk to. I have residents where I work. I don't have fellows, but I have students of all sorts. I have sonographers. I have nursing personnel in labor and delivery, antepartum, postpartum. I have social services I engage. I have chaplain services and local pastors. My local priests will be involved. My rabbis will be involved. Anyone else who's of faith for that patient is involved. And then we have extensive grief counseling that we or social services or the chaplain services provide. And we put all that together for these patients because these people truly need a really extensive very holding close type of care. Again, high touch, not high tech for the most part. Well, for those of you who like line diagrams, I apologize, it's a little bit off kilter. The adjustment didn't work quite right. But if you look at the way it's done, we talk to our patients very carefully and help them understand that they can do interventions or no heroic interventions. We allow ICU care perhaps, IV fluids. We may do closures of hernias. We may do surgical procedures. They may do feeding tubes. There's all sorts of things that patients can do. Oxygen, morphine, other things that they might want. But we let them talk to our neonatologist and us, and they get to participate and decide what they would like to do, not what we think they should do. Well, let's talk about my experience. I have two experiences. One, I was in the U.S. military because I was owed time. You know, time or money. I owed time because I served in the military. And I was at Madigan Army Medical Center in Washington State. We had 33 patients that we did our first paper on. Out of the 33 people that we actually offered this to explicitly, we had an 85% of our patients chose hospice. Everybody says, well, that's care in the military. They don't have to pay for their care. You know, it's not really a fair comparison. Well, we'll talk about that in a minute. All of them were very positive and had opportunity to spend time. We had about 40% stillbirth rate. Keep that in the back of your head. Only 61% had live birth. The live birth breakdown, we had, again, 61%. We had 11 of deaths. We also had 5 cesareans, which everybody goes, well, why'd you do cesareans? Well, if the patients have autonomy and they want a live birth and they want to baptize their baby and they want to spend time with a live baby, I don't have a problem with that as long as you counsel appropriately. And people disagree with me, and that's okay. I'm all right. I'm okay with that. But I'm very okay with doing that, and I'll show you which we did them for anyway. 4 preterm and 8 term. The ones we did cesareans on was a thanatophoric dysplasia. The head was just simply too large. We had a large posterior encephalocele, cloacal dysgenesis, a 34-week encephalocele with renal agenesis, and encephalocele and lethal skeletal dysplasia, all for maternal requests so they could have live babies and spend time with their babies and their families. So again, decide what you'd like to do with your patients and respect that. Oh, where's this? This is my daughter, Mercy. It's in Rome. Does anybody recognize that? St. Peter's, right? Yeah. What about in a civilian? I'm a bit of a peripatetics, as we say, perinatologist or maternal fetal medicine. I've been around, as we say. Some people say you can't hold a job. Maybe that's true or not, or maybe it's just I like to wander. But I was in Rockford, Illinois, and I did my second look at 28 patients. Now, this is in the non-military civilian world, if you will, as I call it, non-military. And we had 28 patients, of which 75% chose perinatal hospice. And everybody was very positive about this. And 76%, about 24% had stillbirth, or 76% had a live birth. And we presented this data actually at a meeting previously. And if you look at the delivery breakdown, we had 1 cesarean, we had 15 vaginal deliveries, and most of the infants died within a minute to about 2 weeks after delivery. We had 1 child with a trisomy with anomalies that ended up living about 2 weeks. Where's this? Anybody recognize this? No, that's okay. Fatima. The only reason I put that in is because I like the picture. It's one of the few pictures I've ever taken that actually looks like the building, right? Well, what about our combined experience? So what we did is we then did a complete look at both of these different things that we did, both in the military and civilian world, and said, well, what was our lifespan? It was about 20 minutes to about 256 days. The one that was 256 was a trisomy 18 with a cardiac defect that ended up living not quite a year. Patients and families all were very, very happy with this. We're very glad they could do it. They had both religious, as in the ability to baptize their children, spiritual opportunities to spend time either having time to bless the babies, baptize the babies, or spend time with their pastors or their priests or their rabbis. Also opportunity for funeral and memorials, which they really, most of these people desperately wanted to do. So they did not want to have disposal of the babies by the pathologists. They wanted to bury their babies. And it mirrors the previous experience. Dr. Spinato did this in '95 and did 5 cesarean sections for fetal anomalies and had very similar outcomes, no problems. Small numbers, but at least we have not had any major problems. Well, the other really interesting thing that you'll find from this is that the siblings also get to spend time with the babies, which doesn't happen if you do destructive procedures or you do deliveries that are less than optimal, because it's difficult to have these babies for viewing. It's difficult to have the babies for them to spend time with. And also, the siblings are there at the delivery and get to hold their baby brother or sister for that amount of time they have. The professional satisfaction for the care team, I can't tell you how much this really has improved everybody's morale and how much everybody likes doing this. And it's the preferred way at my hospital. We actually, everybody would rather do anything would rather do hospice above anything else. The other final thing is that there's an opportunity for physical examination, autopsy, and genetic testing, confirmed diagnosis, and for counseling. If you look at a lot of the previous literature in the United States, particularly in the Wisconsin registry, 25 to 30% of the time the diagnosis is changed by an autopsy and by physical examination. So I really like patients to get that after the deliveries. And finally, I put this up here because this is one of my favorite cartoons of all time. This is from the 1950s in an American journal. Remember we talked about we were all going to do something. We all knew what we were supposed to do. We're going to get people to get over it. We knew that was the thing they should do, and we should help people get through this. Well, doctors thought that cigarettes didn't cause lung cancer either, right? So doctors can't be wrong. Well, if you look at hospice, I think that we were wrong, and that, in fact, we weren't looking at the facts and what patients really wanted. Well, so where are we now? Where are we now? Well, in 2012, believe it or not, since we've been doing this about 1996, 97, somewhere around that 98, there are now over 150 programs in the United States. There were 82 years ago. And these are not anything I had anything to do with. My disclaimer is I don't franchise, I don't own, I don't have a lock on hospice, okay? They're hospital-based, they're clinic-based. In other words, sometimes hospitals will take this on as part of their healthcare system. Sometimes they'll do it as a hospice base, or the local hospice will take this on. In my town, we actually have 2 hospitals, and in our culture, that's competing. So it's better to have a community-based hospice that takes care of the children versus hospital-based, because then they'll get referrals. And then there's freestanding hospice that some people have that are just local community resources, like I mentioned. There are 15 international, and there's actually one hospice that I found is on the list from Ireland. If you go, and I'll give you the list, I'll give you the website that talks about this, where you can find information on it, both resources and information. There's one in Dublin I found. It's called the Little Lifetime Foundation, and all this stuff is available, obviously. The website with all of the information, including references to papers, also research, parental resources, lists of people for referral, and also programs is all on perinatalhospice.org, and that's kept current all the time by Amy Kubelbeck, a dear friend of mine who really had a child with a hypoplastic left heart, actually, and took this on and keeps this updated all the time. And there's also some really good chat lines on this, good parental resources. So what are our challenges? I think the challenge is always as a physician, and particularly those of us who do a lot of complicated things, or those of us even don't do such complicated things, that we get into ruts. We get into ways of thinking how we should do something. We know how it should be done. And that's what I thought until I really started looking into this and doing the literature searches and evaluating what my patients wanted and evaluating what was best for my patients. And what I think that we need to do is examine our own responses and motivations. Am I uncomfortable with this lethal anomaly because it's uncomfortable for me, or is it because I'm uncomfortable for my patient? Who am I really concerned about? The second thing is to rethink our care algorithms. You know, how might we make it better? I learn that every day. I'll be honest with you, I still don't like the way I take care of miscarriages at my hospital. It's uncaring, it's not compassionate, it's in the emergency rooms, it's in the surgeries. It's just not acceptable, and I still fight that every day. They deserve many of the things we've talked about here: compassionate care, grieving, a lot of support, and I just don't get it in my country, to be very honest with you. There's a tendency to withdraw from painful situations, and I understand that. So I would urge every one of you here, if you don't like this, quote unquote, and you do not feel led to do this, don't do it then. If you don't think you can move through that and learn and be compassionate and do it. And I don't have a problem with that. Refer them to me or refer them to somebody else who will feel free to do that. There's things I don't like to do either, like I don't like doing GYN clinic anymore. I know it sounds terrible, doesn't it? But I'm maternal fetal medicine. I like high-risk pregnancies. So I don't do much of the GYN anymore. I'll let you all do that. Institutionally, this is where it's the most fun, frankly. Interdepartmental barriers, communication and coordination, wow. Talk about silos. Nursing won't talk to physicians, who won't talk to labor and delivery, who won't talk to antepartum, who won't talk to. It just goes on, doesn't it? I feel like instead of being in a community, I'm in some sort of a silo someplace separated by these walls. That was one of my hardest things to deal with, frankly. Meetings help a lot. Get a champion in each group. The final thing is, sit down with yourself. Again, I don't do franchise. I don't do bureaucracy. I don't do top-down. I think it's a disastrous thing to do that if you can avoid it. Let the local people decide what they would like to do and how they want it to be done, but include key things about care: antepartum care, intrapartum care, postpartum care, and how that looks. And then develop your own standards and policies and use checklists to help you make sure you're meeting the needs of your patients. Talk to them and they'll help you a lot. Final challenge is I would continue to ask people to collect data, to continue to do research. In fact, right now I'm in the middle of a research project collecting my own hospice data from where I'm at now over the last 7 years and looking at my data again and reassessing, you know, what am I doing and where have I been and what have I done? Has there been anything out of the ordinary or different than what I've seen previously? And be willing to change what I do based on that. Multi-center experiences would be great. In other words, some people have done this as well, would look at their own programs of how they handled it and what they did. I think centers of excellence may need to be established, such as a tertiary care center or university center, because of resources. I mean, this requires a lot of resources. And I think the biggest thing, and part of the reason I'm so ecstatic, I would use the word, of being invited here, is to be able to inform patients and communities that this is something out there that you can offer. You can offer them this care. You can offer them a wonderful opportunity to spend time with their child and with their family, and you can make this situation as positive as it will be with the loss of a child or a loved one. And you can really do some wonderful things with this. This is my daughter's choir. singing at the United Nations this summer, and I'm very proud of that fact. It was the 50th anniversary, and we were the only choir invited from the United States, and we're from West Virginia, a very small part, you know, not about the size of Ireland, actually. And my daughter, you can't tell, is all the way over here. She's a little blonde over there. She's singing over there. You can't hear her, but she's over there. So what's the conclusion? In my country, in my world, there's a lot of patients who need this. And as you start asking the question, you find there's more. Sort of like a lot of things, if you start investigating the problem or asking the right questions, you find there's really a lot of people out there that either have had a baby with a problem, or do know somebody's had a baby, or will have a baby that has a problem. Guarantee in your practice you're going to see this. You absolutely will if you practice long enough. There's a significant number of patients who like it. If you offer this, 75 to 85% of my patients, just in my small numbers, and actually I've talked to other people, it's similar. Their experience is very similar. They just haven't published as much. There's no increase in morbidity that I see. In fact, I think there's less. I think there's less psychological issues involved in the grief and the traumatic stress syndromes that happen. I think are less with letting people be parents, as I say, and deliver their babies. It also shows our compassion for the most helpless of our patients and allows us to truly exercise that wonderful thing we have as physicians to provide wonderful compassionate care and do the things we love to do, which is take care of pregnant moms and their babies. That's it. Thank you very much.